So in this video, let us see the demonstration of a PMMC flap for a pharyngeal defect. So this patient presented to us with a suicidal attempt over the neck. He presented to some other hospital where he was managed conservatively, and around 8 to 10 days after the event, after the insult, he presented back to us. So you can see the Riles tube going through the defect, and that what we can see is the pharyngeal defect. So we have planned this 3 by 3 centimeters flap. The inner circle, which is marked 3 by 3, is the actual part of the flap which will go over the defect. The outside ring over it is the part which will be deepithelialized. Planning is like the conventional PMMC flap. The skin island is centered over the pect major, medial to the nipple areola complex, and that is the planning. The markings and all we have discussed in other videos. So it is a typical PMMC. We have taken a larger skin paddle because we didn't want it to be very tiny. Smaller the skin paddle, less are the chances that there would be some prominent musculocutaneous perforators entering into the skin. That is why we took a decent skin size of around 3 by maybe around 6 by 6. Now we are creating a tunnel from the upper part of the flap till the clavicle. So we could have made an incision as well, but that would have given two additional scars. The dissection in this particular way makes it a bit tough for the surgeon, but nevertheless it is a bit gratifying. Now what we are doing is we are going from the clavicle towards our flap, the proposed flap. We will be creating a tunnel between the clavicle and the flap so that the flap can be delivered through this tunnel and then again taken into the neck. So this, as you can appreciate, is a significant sized tunnel. Now what we are doing is through the same clavicular incision, we are going towards the neck, towards the defect. Again, a similar tunnel will be created. As you can appreciate, these are avascular planes. If we go into the right plane, it is a bloodless plane, plane of loose areolar tissue. Same thing we are doing now from the defect side, and we will reach to the clavicle area, and this tunnel would be joined. So again, you can see that this is a significantly wide, large tunnel. Now what remains is for us to harvest the flap. Tunneling is already done. Since the defect requirement is less, we are not taking the entire pect major. We are taking only a part of the muscle, which is underlying the skin. The lateral part of the muscle, I would say we will keep it in situ. We always initiate the flap harvest, the muscle harvest from the lateral end because it is a bit easier. We also are able to appreciate the lower part of the pect major, and we can ensure that our entire skin paddle is overlying that muscle. Flap harvest is now pretty straightforward, like the conventional PMMC flap. Again, there is a very distinct plane of loose areolar tissue. We have to go above that plane. Whatever perforators are encountered towards the midline as well as during the course of flap harvest should be cauterized, should be transected, and the flap harvest continues. So this is, I would say, a technically bit demanding flap to harvest because we are doing it through limited incisions. What we are seeing beneath is the pect minor. Now we have raised the flap comfortably to be tunneled it from the incision over the clavicular region. Rest of the flap we are now harvesting through that area. The medial part of the pect major is currently being incised so that we reach the clavicle, which would be our pivot point of the muscle. In this particular region, we have the clavipectoral fascia as we reach near the clavicle. So we might need a bit of a sharp dissection there to take care that we don't damage the pedicle. Here we have the pectoral branch of the thoracoacromial. We also have the lateral thoracic artery, which is in the lateral aspect of the pect major, which is somewhere near the deltopectoral groove towards the lateral aspect. So we have to take care not to damage it, and we can sacrifice it as well when we confirm that our dominant branch is the pectoral branch. Here you can appreciate that this is the lateral thoracic artery. Can clearly appreciate it. We are going to sacrifice it because it would add to our reach. And in addition, we can also see that the pectoral branch is a dominant branch over here. So we sacrifice the lateral thoracic and we continue the flap harvest till the clavicle. We can also appreciate the nerves. Some people tend to transect the nerves. I think it is a matter of individual preferences, but it is always better to transect the nerve because the contraction of the muscle goes down significantly. Now, what we are doing here is we have marked the exact dimensions of the defect. We will deepithelize the extra skin. You can see that it is perfectly bleeding well when we are deepithelizing the area. Full thickness of the skin is removed. So that ensures that only what area of the skin is required goes into the defect, and rest of the skin doesn't have any epidermal elements, rest of the tissue doesn't have any epidermal elements. So once that is done, we have this button like thing. We are now tunneling the flap into the neck in such a way that our skin island is going to go over the pharyngeal defect. As you can see, the flap is comfortably reaching the defect and the skin is going to go over the defect. So we are taking multiple long sutures to begin with and then burying the skin into the defect. Yes, so this is how the skin was sutured. Just a few sutures to demonstrate how it was done. And this is the on table picture. Pre-op, post debridement and post settled flap. A very well settled flap we had. We had no issues whatsoever. You can see the scopy picture wherein you can see mucosalization of the skin pedal which has gone in, and it was a very fast relief, I would say, for the patient. In addition to this, the tracheostomy needs to be removed, which will be taken care of by the ENT department. And again, this is a lateral view wherein you can see that the frontal view with the donor site of the PMMC flap. Thank you.